A 62-year-old female presents with neck pain. I am showing you the lateral cervical spine radiographs in flexion and extension. Describe the findings.
Okay, assessing the provided imaging. The lateral radiographs of the cervical spine demonstrate lateral views in flexion and extension. On the flexion view, there is significant widening of the atlantodental interval, indicating acute atlantoaxial joint subluxation. The distance between the posterior aspect of the anterior arch of the atlas and the anterior aspect of the odontoid peg measures well over 3 millimeters. The odontoid peg itself shows irregular margins, consistent with partial bony erosion. On extension, the subluxation is partially reducible, though the atlantodental interval remains abnormally wide. The remainder of the subaxial cervical spine is relatively well preserved, with no severe disc space narrowing or facet joint subluxation. The appearances are highly suspicious for atlantoaxial instability, secondary to rheumatoid arthritis.
I'm showing you two comparison images, a sagittal cervical spine tone MRI and a radiograph of both feet. Describe their findings.
The sagittal T1-weighted MRI of the cervical spine confirms significant atlantoaxial subluxation and erosion of the odontoid process. There is a large mass of low T1 signal synovial pannus tissue surrounding the eroded odontoid peg, causing severe compromise of the cervical spinal cord. The comparison foot radiograph shows bilateral, symmetric erosive arthropathy involving the metatarsophalangeal joints. Classical features of rheumatoid arthritis are present, including periarticular osteopenia, uniform joint space loss, and marginal erosions.
Explain the diagnostic criteria for atlantoaxial subluxation on plain radiography in adults and children.
In that case, atlantoaxial subluxation is diagnosed when the anterior atlantodental interval, or ADI, exceeds 3 millimeters in adults on a lateral radiograph. In children, because of developmental cartilage thickness, the normal limit is up to 5 millimeters. Flexion and extension views are crucial because the instability is dynamic. The subluxation is typically maximum during flexion. Additionally, one must look for vertical subluxation, also known as cranial settling, where the odontoid peg migrates superiorly relative to McRae's line.
Describe the pathogenesis of cervical spine involvement in rheumatoid arthritis.
Well, rheumatoid arthritis is a systemic inflammatory arthropathy characterized by synovial hypertrophy and pannus formation. In the cervical spine, synovitis affects the synovial line joints between the anterior arch of the atlas and the odontoid peg. The inflammatory pannus directly erodes the odontoid process and destroys the transverse ligament, which normally tethers the peg to the atlas. This ligamentous laxity and bone destruction lead to hypermobility, causing the atlas to slide anteriorly during neck flexion.
Discuss the clinical implications, complications, and how you would manage this patient as a radiologist.
Okay. Severe complications of atlantoaxial subluxation include cervical myelopathy, quadriplegia, and sudden death from brainstem compression. It represents a major airway risk during anesthesia, as hyperextension during intubation can cause fatal spinal cord transection. Therefore, preoperative flexion extension radiographs are mandatory for any rheumatoid arthritis patient undergoing surgery. As a radiologist, I would immediately call the referring clinician to report the unstable subluxation, recommend neck immobilization in a hard collar, and suggest an urgent MRI of the cervical spine to assess cord compression.